don't talk about it. You know what I mean? Like,
This is Dr. Jerry Hesch. This is my client, who has a rather complex history. I'm going to just focus on the fall. He fell on steps. And what year was that?
in 2000, late 2015.
Very good.
Yeah.
Very good. And I know that that was in your history, but I could have guessed that you fell on your stairs because of the way your pelvis presents. He presents with a pattern that I call posterior glide fixation of the sacrum. And making that statement, certainly a lot of folks are going to jump on and say, the SI doesn't move that much, you can't test it, yada, yada, yada. You know, been there, done that. I keep up with the literature. This is a very unusual injury for a male. It rarely will present in a female that delivered a very large baby, but usually it is a fall onto their sit bones. I told one patient, I said, you fell because you didn't have a baby, so you must have fallen. She said, no, I didn't. She went home and told her mother, the therapist said I fell. She said, yeah, remember, blah, 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 you know? Yeah, she fell. And so to the best of my ability to discern what happens, this is how I put it together. When you fall, that's a profound force. It's a very unusual force. We don't fall in our day-to-day existence, right? This is not what we do. And so it's called non-physiologic. And it was enough force that your sacroiliac joint gapped a little bit, okay? But your trunk flexed forward, okay? And it sent the force right through the absolute middle of the joint. It's shaped like a boomerang on both sides, and the force went through both sides, and it literally pushed sacrum posteriorly, okay? Now, we don't have imaging studies pre and post. I get that. I know what's missing in the literature. I know what the literature tells us and what it doesn't tell us. And this is a knowledge gap. It is what it is. You feel very rigid there.
Yes.
Okay. And when you walk, you look very rigid in your pelvis. Okay. And every joint in the body has a subtle little movement in it. And so I should be able to lean on your ilium with 15 pounds of force, maybe 20, and then spring it, and it should spring forward and recoil back. And that should happen in many directions in your pelvis. You don't have any movement. I cannot get that movement. And when I palpate your sacrum sits posterior to the ilia. Okay? And this ligament and this ligament are rock hard. They feel like bone, but down here there's no bone. It's just ligament and muscle. Yet it feels like a bone. It's so tight. Okay? In response to that, when the sacrum glides backwards like that, if that, you know, it will push against the facets at L5, and it'll block spring mobility of L5. Okay? L4 can take a beating because it has to move more. It has to do what L5 can't do. So you tend to flex above L5. Okay, it's basically your weight is shifted backwards. Okay? And so when you stand, it's like your bum shifts back a little bit.
Yep.
But in response to that, you're not going to stay with it, you're going to counter it. Okay? So if I stand and I shift my pelvis backwards, I immediately bend forward, but then I have to hyperextend. And so what I find is people with this pattern, they hyperextend in their mid-thoracic and they hyperextend in their neck. So let's have you lie on your back and I'll show some of these motion deficits. And again, it's just really rare in a male, but it is what it is. So I didn't look at you and say, oh, I bet this guy has this posterior glide sacrum, you know? It's right. So rare, that didn't cross my mind. But look, I can't even spring this. I cannot load it and spring it. I can load and spring your rib cage. So I'm pushing in the rib to a stop point, and now I thrust it and it bounces forward and it bounces back. Okay, but you have no movement there. When I try and glide your pelvis sideways, there's no give. Lie on your stomach.
Okay.
There's no spring in that direction, no inferior spring, and I'm using a lot more force than usual, no upward spring. On the sacrum midline, no spring whatsoever. So L5 should be right here. If we come that way, you have kind of subtle shape of the PSISs, okay? Anyway, if I spring what I believe to be the upper sacrum, I get no movement. This, I think, is L5, no movement. I think this is 4. All of a sudden, I can spring it, okay? And, you know, someone might say, well, he probably has inflammatory spondyloarthropathy, such as ankylosing spondylitis with SI joint fuses. Well, you've had this long enough. This goes back to what year?
To the end of
2015. Yeah. You've had this long enough that if that was ankylosing spondylitis, you would be fused in your thoracic vertebrae and in your rib cage, and I can spring up there. Okay, so that's not the issue. Now, the sacrotuberous ligament is deep here. Okay, I'm on it right now, and I'm trying to indent it. Feels like bone. I cannot spring that ligament. Okay, I'm going to show the response of your body, which is driven by a reflex called a righting reflex. If you're typical, then we'll find a place of significant restriction up here. So far you're moving, and right here there's no movement. Do you feel that?
I feel it.
Yeah. So you're reflexive, and above it I can spring. Okay. So there's going to be at least one rib, I believe, that won't spring, and that's right here. Feel that?
Yep.
It's just not moving. The other thing that happens, if you could lie on your back, is that there's not enough movement there to fully compensate for that posterior shift. And so the body turns on the suboccipital musculature, and it keeps the atlas hyperextended. So I'm going to put my index finger beneath the occiput. I'm on the mastoid. Now I slide behind. I can feel the occiput, and I'm pushing up, and now I'm trying to spring to the left, and I'm trying to spring to the right, no movement whatsoever, okay? And then I'm on the transverse process of the atlas. I'm trying to spring it left and right, no give. I'm going to get on 2 now, and boom, we have movement. So C2 happily moves, but not C1, okay? And it's not the occiput at the joint it makes with the first vertebrae, the occipitoatlantal joint, because I can get that early rotation springing the occiput, and I can get that subtle side bending right away, okay? Now, in order to test traction mobility of the atlantoaxial joint, or the C1, C2, I have to have the force in front of the ear, because those joints are right below the earlobe. They're in the front of your neck. All the other facet joints are in the back. So my contact is going to be on your temples.
Okay.
Oh my God, it feels like I'm trying to pull a huge block of granite. There's no give. If I put you in extension, it gets worse. We did that already. If I put you in 15 degrees of flexion, all of a sudden we get a little bit of mobility. I can get that traction, and then I can spring it. Do you feel that?
Yeah.
Okay. So the treatment I developed is quite simple, and I'll demonstrate it. Let's have you lie on your stomach.
Okay.
It takes time. That SI joint is such a strong joint that I can't possibly manipulate it. Some people believe you can, but I think when people try and it makes a noise, I think it's the facet joint that is actually being adjusted. So, secret is it takes time and it takes a fulcrum. So what I'm going to do is place this 3-inch tall foam under the bony pelvis in the front. So roll a little bit. Good, come on it. Nice. We're going to do the same thing on the left side. And then I'm going to put this one on the left side, okay? And then I'll put 2 pillows under your ankles. Are you comfortable?
Yes.
Okay, lift your feet up. Keep them up. One more time. Good, down. There we go. All right. So this force is directed at the hemipelvis on each side, and it's gliding them towards the ceiling along the shape of the joint. So up and in is what they're doing, and sacrum is just kind of hanging there. All right? We're going to do this for 5 minutes. I'll take the pillows out and test the mobility, but I think that I'm going to have to go forward and then keep the foam underneath the pelvis. And then I'm just going to use my forearm, and I'm just going to lean on the sacrum with perhaps 20 pounds of force. The secret is I'm going to keep it there for 5 minutes. Okay? And this is a most interesting case because it's so rare for a male to present with this pattern. If they do, they're usually pretty tall and lanky, and I don't think that describes you, does it?
No.
All right. Now, the person I treated in Las Vegas, I had follow-up with him about 3 years later. He had severe constipation, and he had the most perfect diet. He was very conscientious of his diet. He had this pattern. When I restored the mobility, his bowel behavior became normal. Lasted 3 years. He's in touch with me. We're on LinkedIn, and he's never contacted me and said, I need you to do that again. It's usually a one-time correction because we do it precisely. We respect the biomechanics, the arthrokinematics, how joints move. We apply a reasonable force that doesn't intimidate the nervous system. And in this example, we maintain that force for 10 minutes. So it should be a one-time correction. And I think you're going to be surprised at how you gain mobility in the thoracic spine and gain mobility in the atlas without us having to do anything to your neck and T-spine. So I'll stop filming now. By its nature, it just had to be a long video. It's 13 minutes. I'd better stop. And we'll come back and film the results.